Hello. This is the comparative ocular pathology rounds. And it is now 8 o'clock, so we're going to get started. My name is Megan, and I'll do the first two cases today. So our very first case is a horse. This is a 20-year-old thoroughbred gelding. Uh, this horse has severe posterior segment abnormalities with bolus retinal attachment, recent cataract formation, severe corneal edema, and mild keratitis as well. Has been treated with intravitreal gentamicin and episcleral cyclosporin implants, um, and ultimately ended up enucleated. The other eye has similar findings. They do note in the other eye pigmented keratotic precipitates, iris depigmentation, incipient cataract, peripapillary retinal edema, and chorioretinitis. So ultimately in this horse, they suspected heterochromic iridocyclitis, which more on that later, or heterochromic iridocyclitis slash keratitis. So those are kind of the things I'll share mainly for this horse case. In our gross exam, there's a couple of things that are handy to note. Maybe you can kind of make out over here that we have our cornea roughly from here to here. It's a bit wrinkled following formalin fixation. It is also thick, which is sort of a real finding, I would say, and kind of cloudy, maybe cloudier than you'd expect just a formalin fixed cornea to be. But maybe here you can kind of put on your imaginoscope and see that there's like a very thin saran wrap-like layer sort of separating out from the retrocorneal surface. So the gross examiner in this case suspected a Descemet's detachment, and more on that later. The other things you can see in the gross view, along the ciliary body surface, you have this sort of whitish film, and the retina is detached. And then actually you have this kind of like folded up piece of retina here close to the optic nerve, which suggests it could be really torn, but we'll take a look at that histologically. And then the last thing that I'll point out is we have in the episclera up here, sort of right up by the limbus, these weird little tannish doodles. And these guys are usually easy to cut through. Oh, thank you. When you see them intact, they're like these long, sort of noodle-like structures. And so these are actually the cyclosporin implants and what they look like on cut surface embedded in the episclera or subconj where they've been placed. The idea with these is a slow release of immunomodulatory therapy. So I'm going to pick the right thing. Here we go. And we're going to take a look at the histology. Like this, perhaps like this. There we go. And let's give a subgross a shot. We have some goo on the slide, which maybe I can get rid of. So we do have a kind of folded up cornea. Even from subgross here, you can see that the cornea sort of has this pale eosinophilic stain, which is sometimes one of our only indicators histologically of a true edema. Be cautious about overinterpreting gaps between corneal stromal fibers, but sort of an overall pale stain like this can indicate a real edema. We do have a break in Descemet's, which we'll look at closer, and here's kind of one end of Descemet's here. And even from low mag, we we have this sort of pinkish film over the ciliary body surface, which we'll take a look at closer. All right, let's go ahead and pop it up here. There we go. So again, with our kind of edematous cornea, ignore the goo. Maybe we can get rid of the goo. I'm going to give one more shot at getting rid of the goo.
I thought that big blob of pigmented cells.
Ah, yes, will do. Have a request. Here we go. That's better a little. There's still some stuff on it. All right. So we had a request. While we're here, we have this sort of ball of pigmented cells at the tip of this iris leaflet. So here's the iris coming in, and there's this ball of pigmentation. Can anyone answer what this structure might be in the eye of the horse? It's the internal sunshade of the eye, like wearing sunglasses inside your eyeball. Maybe. We got some head shakes here. All right, it's the corpora nigra. This is the corpora nigra, the internal sunshade of the eye. Anyway, CUAL anatomic landmark. Superior in the superior aspect, yes. Um, you would wonder whether this could be artifact, but something that you can see that suggests this is a true Descemet's attachment is a little bit of deep corneal stromal fibroplasia here. So this is a real detachment and break in Descemet's. So that's one feature of this case, but let's, without further ado, head over to this fuzzy ciliary body surface. And if we zoom in closer on that, we have the pigmented layer of the ciliary body, then the non-pigmented layer, and then there's this extra layer of stuff, which is extracellular and kind of maybe a little bit homogeneous. Maybe if you go zoom in really close, kind of finely fibrillar. But basically, this is amyloid. So we've got some amyloid deposition on the ciliary body surface. If we stain this with Congo red, it would be congophilic and apple green birefringent. And maybe as we look around, we could find some eosinophilic linear inclusions in the non-pigmented ciliary body epithelium, which I'm probably going to not spend a long time on because there's not too many in this case. But that can be another feature that you'll see in some of these cases. You do also actually have inflammation in this uvea as it is histologically defined somewhere. It's not really all that obvious in the anterior uvea, but there's actually more of it in the choroid, so we'll get to that. You've got like 5 lymphocytes and plasma cells in this field, maybe. We have some skeptics in the room giving me some looks. Well, then I'll show you this area in the choroid. So there is inflammation in the uvea. Here's a better area. Which was interestingly much more heavy in the posterior segment, which is something that they noted clinically. That's kind of an unusual feature of this case. But here's some lymphocytes, maybe fewer plasma cells. Another kind of weird feature is that there's occasional histiocytes amongst this inflammatory infiltrate too, which isn't necessarily common. So before we keep showing you stuff about this case, we're going to stop for a second and discuss this fuzzy pink stuff on the ciliary body surface. So just amyloid deposition or on the ciliary body especially, it can be a little bit more extensive inside the eye, deposited on other surfaces too, but ciliary body is most common. This is considered the diagnostic feature of equine recurrent uveitis, currently at least. The linear eosinophilic inclusions in the non-pigmented ciliary body epithelium can be a plus or minus in terms of diagnosing ERU. And then whether or not you actually have inflammatory infiltrates in the uvea by the time of enucleation is also a plus or minus, keeping in mind, of course, that some of these eyes may come to the pathologist having been treated, as this one was, with immunomodulatory therapy, which could potentially affect why we sometimes see inflammatory infiltrates and sometimes don't. So there is that. Kind of interesting feature in this case is that they thought clinically it looked more like heterochromic erocyclitis, which is a condition that tends to involve pigment dispersion. So melanin-laden macrophages will be in the uvea. You get iris depigmentation as that pigmentation gets gobbled by the macrophages. You can get a retrocorneal membrane with some pigmented-laden macrophages in it. And that's kind of another entity in horses that's been described. Interestingly, we've seen overlap in, for example, the amyloidosis that is thought to be diagnostic of ERU and features of HIC in other cases. So it's possible that maybe the amyloidosis isn't as specific as once thought, or something along those lines, but and so it's sort of more on that later, stay tuned. But for now, in terms of classical education, I would consider ciliary body amyloidosis diagnostic of ERU.
So what, tell me more about heterochromic uveitis. What does heterochromia have to do with it?
It's called heterochromia at least because of the pigment dispersion in the iris. Clinically, you'll see a progressive depigmentation in the iris, sort of patchy depigmentation. And then histologically, what we see is sometimes you can see from low magnification, like essentially there'll be areas where the resident strobel melanocytes sort of aren't as plentiful. And then if you zoom in, you'll see macrophages that have been phagocytizing melanin, sometimes even multinucleate macrophages, which is the histologic correlate to that. So the heterochromia. Yes.
So so when you say heterochromia, I immediately assume that the animal has two different colored eyes, and you just named a disease with that,
Yeah.
right? And so I'm pretty sure I'm not alone in wondering why it's called heterochromia. So there's color change in the iris, right?
Yes, it's like an acquired
So do these
heterochromia.
horses, do their eyes turn blue?
I don't
They
think,
can.
Yeah.
yeah, like fully blue.
Yeah, there was a really dramatic case that we got. It was like a
Interesting.
brown iris that went completely gray.
Huh.
That's
Yeah,
cool.
it was crazy. And when you looked at it histologically, until you got to higher mag, there was plenty of melanin in the iris. But when you went to higher mag, it was all in macrophages, not in melanocytes. It was crazy.
Wow.
Yeah.
Okay. That's a
Yeah.
new one for me.
Yeah.
Also keep in mind that heterochromia in terms of like genetic heterochromia can present in the same iris. So we do sometimes get like segmentally brown, segmentally blue in like one eye. But yeah, the classic is like one eye brown, one eye blue.
And to add a little bit more about this disease, the paper was published maybe 10 years ago about it, and no one knows why it happens
Mhm.
and why it was only described 10 years ago. We went back and looked at a lot of our horse eyes prior to that, and we definitely had cases of it that we just didn't recognize.
Wow.
So it's been around and no one knows why it happens. I mean, it seems like it should be some sort of autoimmune problem, which I mean, technically ERU probably is also some sort of, yeah, but
More study is needed, long story short.
Okay.
yeah.
Yeah.
Nikki, the question.
What?
Question
Oh, yes, of course.
The hyperplasia associated with Decime's break, how long does it take to form that? Because I feel like sometimes we see really acute breaks, we don't always see that corneal change. So like, what's the time frame for that?
I can't give you so the question is, what's the time frame for deep corneal fibroplasia associated with breaks and or detachment of Decime's? I think that part of what might be confounding as well is that not all breaks and Decime's will develop a fibroplasia. So like a lot of breaks that we'll see on a routine diagnostic basis are Hobstria, for example, like basically just a ophthalmic eye, and you get these multifocal breaks and Decime's. Sometimes those heal pretty uneventfully. Essentially, you'll just see a very clean break with no deep corneal fibroplasia. The corneal endothelium will migrate across those, that it'll lay down a new layer of Decime's. And then you end up getting like a doubled spot if it's later in healing. And like fibroplasia essentially isn't a part of that healing process necessarily. Um, I would say, like anecdotally, we see fibroplasia associated with Hobstria more frequently in younger animals. That's super anecdotal, though. And it's more common if there's actually like a detachment, like a full-on peeling of Decime's rather than just a break, like with Hobstria. In terms of your actual question, like what exactly is the time frame of fibroplasia developing if does develop? I'm not sure. Do we don't know. We're getting head shakes otherwise. But yeah, part of the confounding thing I think is that not every case of a break in Decime's will develop fibroplasia in the first place. So
Megan, can you hear me?
oh yes, Leandro.
Yeah, one of the things that I think happens in these cases in horses, especially when there's not just a break but a separation of the descemet membrane, is there's a more profound imbibition of the aqueous humor into the corneal stroma. And the aqueous humor has a lot of TGF beta, which is a pro-fibrotic substance. So I think that also plays a role in that deep
Yeah, and
stromal
maybe it's just the
fibrosis.
size of the break to some extent, or like
Right.
the size of exposure of the cornea. Yeah. Thanks, Leandro.
My second question is, do you know if these horses have high levels of circulating amyloid? No, they don't. It's just like localized to the eye. I was just curious if like someone would support that.
And then filter with the nose.
There are not high levels of circulating amyloid A is what came of the question and answer just then. In horses with ERU. Uh, yeah, good questions. Any other questions? Okay. Um, so the last couple things to show, this horse has a pretty significant cataract, but we're just going to skate right over that. Here is the detached retina, and this is a torn end. You can tell a true in vivo tear in the retina from an artifactual tear, because a torn end in vivo will sort of atrophy and kind of curl on itself, like this one is doing. You can see kind of that curled and atrophied end. Whereas a tear, artifactually speaking, will just be like a boxy, abrupt end to the retina without like this particular atrophy at the end. Um, So, long story short, this horse was a complicated case, at least histologically in terms of what we know now. The findings histologically are more consistent with ERU than they are with heterochromic iridocyclitis, despite the clinical presentation, and despite some somewhat unusual features. The more like choroid-heavy inflammatory infiltrates and the presence of some macrophages in the uvea was a little bit weird for ERU, but still overall mostly an ERU presentation. And then there's some complicating comorbidities. We typically attribute Descemet's detachment to trauma in horses, although it's possible that it can occur for other reasons, for example, post-operatively and so forth. There's been a paper published on that. And then there's also retinal detachment and tear, which could also be a trauma thing. So it's possible that there's sort of multiple things overlapping in this horse eye. It's worth mentioning that sometimes in eyes that we think are blind for other reasons, they may be sort of less able to protect that eye. And those eyes may be more prone to trauma, which we sometimes refer to as trauma to a blind eye. So I'd wonder if that may have happened in this case. There's also been some other complicating factors like intravitreal injections and so forth in this horse, which, speaking of which, before we move on from this complex case, here's just what the histology on that cyclosporin implant looks like. The implant itself doesn't usually section very nicely, but you can see the space where it is, and it's surrounded by a little bit of a fibrous capsule there. Super cute. Maybe if there we go. Digital polarization, we charge extra for that. Wink, wink. We don't actually charge extra. I'm using my finger. That's just my favorite joke. Anyway, there you go. Cyclosporin implant. It's cute. All right. We'll finally do a different case. There we go. Here's some brief diagnoses on this complicated equine case. And just a quick touch on heterochromic iridocyclitis and ERU and how it's still more study is needed area. All right. We have a cat. Thank you very much to the clinical team for taking this clinical photo. I wish I could give you credit specifically. But this is going on the internet. So this is a 15-year-old spayed female domestic short-hair cat. The eye that we got more recently is let's see, a right eye. And this eye had a history of uveitis in both eyes. And the other eye, so the left eye, was already enucleated back in 2020. And the diagnosis was given by us. So I don't know. We're going to hold on that for a second. And ultimately, the patient was lost to follow-up following 2020, but then came back in with eye drops or really severe corneal edema developing in this eye 2 days before presentation. So really severe corneal edema with bullae. And hypermature cataract in this eye and uveitis in this eye. And that's the main stuff. So you can see it's sort of a cornea that bulges a little bit and is very cloudy. So a really severe corneal edema in this clinical photo. Maybe you can make out what looks like a kind of wrinkled and opaque lens behind that. A little bit hazy, sort of the edge of an iris leaflet here, maybe. All right, let's take a look at the histology. So it turns out that we had both eyes in Coplow from this patient. I'm going to walk you back in time first. So here's the first eye, or sorry, here's the second eye, the one that we got more recently. Pardon the scratches. So one thing that you'll note in this iris leaflet is that there's an interesting pigmented population along the anterior iris surface. And then one thing you'll note on this iris leaflet is that there's an interesting purple population along the anterior iris surface and along the ciliary body surface. You can see that the lens in this case has this sort of like nibbled cookie appearance. It's got sort of Hauschip's lacunae, perhaps if this were bone. Don't you actually use Hauschip's lacunae for a lens that's not accurate. But basically we have, yeah, a scalloped edge. That's a more descriptive way of putting it. So pretty. And then we have some similar purplish stuff carpeting the epiretinal surface. We have some retinal detachment with a little bit of high protein fluid beneath the retina here. We've got an obvious cup and atrophy in the optic nerve head, even from low magnification. So here's some subgross stuff that we can show you. And now let's start by dropping in on this population here. That's the first thing we'll look at. you look at all these purple guys that are carpeting intraocular surfaces, yeah, we have some sad noises in the room. So this is a relatively monotonous population of round cells. They have really big nuclei with open chromatin pattern and distinct nucleoli, so these are pretty active cells. They're fairly mitotically active as well. Maybe, well, never mind. Maybe they're not insanely mitotically active in the fields that we have. But you may see some mitoses here and there. Let's put it like that. And then they have a relatively high nuclear to cytoplasmic ratio, things like that. So this population is pretty suspicious for a round cell tumor. And indeed, the top differential diagnosis for this intraocular population of cells is lymphoma. Just because we want to give this cat more problems, if we migrate over here to this iris, note that it is normal to have at least a slight layer of pigmented cells on the anterior iris surface, usually kind of a 1 to 3 cell layer thick, a pigmented melanocyte layer. But if you really look at some of these pigmented cells that are on the anterior iris surface, and in some cases in the iris stroma, some of them have nuclei with a relatively open chromatin pattern and distinct nucleoli. So I think this one is a little bit tougher to be entirely happy with. Here's another example. But it looks like we've got a feline diffuse iris melanoma in this eye as well as the lymphoma. Although the feline diffuse iris melanoma part is likely in a pretty early stage, mostly in the iris. So 2 tumors, plus if we go back to our Cookie Monster lens, here's the lens capsule. Here's the nucleus that kind of floated out artifactually. We've got phagospaghetti, which is a fun word that we use for the meatballs that are macrophages phagocytizing the spaghetti that is the lens fibers. Maybe it's not a great phagospaghetti case, to be honest, because the noodles aren't really there. But the presence of these macrophages indicates that this was likely an in vivo lens capsule rupture. So these macrophages are responding to exposed lens fibers. Spontaneous lens capsule rupture can happen, but in the absence of an intumescent cataract, we typically attribute lens capsule rupture to trauma. Here's another indication that this was a real lens capsule rupture. You have one end of that ruptured lens capsule embedded in fibrous tissue, and it's kind of curled on itself like this. So these are all features of this lens that suggest an in vivo lens capsule rupture. This was not just artifact and potential trauma in this eye. So we have a lot of problems in this eye that was nucleated, and you wonder, why was the first eye nucleated? We go back to that eye, it's even more striking. Here is the retina and optic nerve in this eye. Actually, let's flip it so that it's the same orientation as the one we just looked at. Retina and optic nerve looking really, really purple. We've got more purple in the choroid and lining the uveal surfaces. The carpeting kind of feature of this is reminiscent of what we just looked at in the eye that we were just looking at. More purple lining. And if we zoom in on this population of cells, once again, we have a relatively monotonous population of round cells with open chromatin pattern. This one is much more mitotically active. You can see a bunch in the field right now. So this again is most consistent with a lymphoma in the other eye, the eye that was nucleated in 2020. And if you look at the lens on this other eye, okay, maybe not convincing there. Hang on, hang on. Boogers.
So is this first eye, did it receive chemotherapy for this, or was this a first diagnosis?
This eye was the first diagnosis in 2020.
So, but was it diagnosed with lymphoma before you got the eyeball?
As far as we know, no diagnosis of lymphoma before the eyeball.
And afterwards, it got chemotherapy, presumably.
Afterwards, it was lost to follow-up. Yes. So, This is an interesting case. In terms of what we diagnose this lymphoma as in this first eye that we're looking at now, the way that it sort of circumferentially is distributed around the eye, we do have macrophages inside the lens capsule. There's a suggestion that there was trauma in this eye as well. Um, we call this so we used to call this post-traumatic post-traumatic sarcoma round cell variant, which is what this was diagnosed as in 2020, and features that suggest that currently are sort of this circumferential distribution, and an indication of not only just trauma in some of these cases, but sometimes just chronic uveitis even, in an eye. We're sort of pushing to rename that entity to chronic uveitis associated lymphoma, or CUAL for short, because we don't want to confuse this entity with post-traumatic sarcoma in the cat, which is the spindle cell variant or the classic variant. That is of a lens epithelial origin. And these lymphomas are most likely not lens epithelial origin. It's lymphoma. Potentially, it could be transformation of lymphocytes against a chronic background of uveitis, something like that. So we're planning on kind of renaming it to distance it from, your post-traumatic spindle cell variant. So basically, in this first eye could have been initially a primary ocular lymphoma. It may have developed in this eye. And the other eye could have had a de novo tumor that developed independently of this first eye. And I would argue that essentially the 5-year gap between the enucleation of this eye and the eye that we currently got could indicate that that story actually could be a possibility. Essentially, like the lymphoma populations in these eyes may not necessarily be related. However, certainly it is worth noting that lymphoma that is sort of multicentric or multisystemic can manifest in the eye. And this patient, like in the reports, we suggested that this patient could benefit from staging. But long story short, it is important to note that some lymphomas can arise as a primary tumor to the eye. Diagnosing ocular lymphoma doesn't automatically mean that you have a stage 5 lymphoma. You need to do the work to stage the patient and check things out. So another complicated case, evidence of bilateral ocular trauma, and basically a widely spaced diagnosis of lymphoma, and then an early feline diffuse iris melanoma in the 2025 eye to boot. So here we go. Let's give the floor to somebody else eventually. Here's some short diagnoses. Any questions or comments on these complicated cases? All right, I'm gonna shift. I've taken enough time already.
I was gonna clarify one thing. Cats don't typically develop intumescent cataracts.
Yes.
So unlike dogs that develop them often associated with diabetes, cats don't do that. So pretty much lens capsule rupture in cats is considered to be traumatic, period.
Yeah. I mean, technically, there are rare causes of intumescent cataract that we would never see. Like specific researched toxins and so forth, and yeah. So.
That whole thing about saying hindsight is 2020.
All right. So this is Jamie. I'm one of the staff pathologists here, and I'm going to present our next two cases. So first up, we have this clinical photo from a 3-year-old mixed breed male neutered dog who had a 1-week history of the left third eyelid being elevated, and soon after the eye became cloudy. The referring vet started on clavamox, carprofen, and fluoxetine with no improvement. So they went to a veterinary ophthalmologist where they diagnosed mucopurulent discharge, severe conjunctivitis, which we can see in the clinical photo, severe anterior uveitis, and early secondary glaucoma. The patient was blind in this eye with, again, glaucoma with an IOP of 24, and they were not able to visualize the fundus. They did note during enucleation that the orbital tissue was a little bit more bruised or swollen in the temporal and superior orbit, but they did not notice any foreign bodies either on their exam or during the enucleation attempt. So We'll go ahead and jump right to the histology here. Do a little subgross here. And grossly, we noticed we got cornea up at the top. We noticed a lot of exudate and pus in the vitreous and the anterior chamber. The iris looked a little bit thick. We can see it's a little bit pale here, and we can see this exudate kind of around. A little bit of hemorrhage, and exudate kind of goes around, kind of lines the retina here. And then there's a little bit of blueness to this tissue out here that we'll take a look at as well. All right. So we'll just head up here, starting at the cornea. You can see a little bit of keratitis and vascularization coming into the corneal stroma here. If we come back into the anterior chamber, we see neutrophils, and here is our iris stroma. Again, looking very edematous. We've got all this clear space separating out the stroma here. We got our neutrophils infiltrating here. We have a lovely little fibrovascular membrane lining the top. And if we head sort of into the pupil here, we can see that a lot of this exudate is just sheets of these neutrophils. Very lovely looking. So this exudate in the chambers, along with this hemorrhage, we start to think about things that can cause like contaminated penetrating trauma. As we look here, very minor, if any, cataract changes. And if we take a look more at the exudate in the vitreous here, we start to see our culprit. And so here, floating in the vitreous, is this lovely piece of plant material. That brings along with it some bacteria. Let's see if we can just sort of give you the little cheap version here of the little refractile nature. All right, I'm gonna ask to do.
It's just a circle on
Oh,
yeah.
all right.
So then spin it around. There you go.
Look at the pretty color.
Raves I want too.
Little raves. Yep. And then we can see a lot of these cocci bacteria in here as well. So there's lots of bacteria. There's this plant material in here. So we do indeed have a penetrating contaminated foreign body. We can see the neutrophils and such head into the retina and out the optic nerve. And then in the episclera here, this is ventral. We can see fibrosis and inflammation and probably some adherence here of this orbital skeletal muscle. So maybe this is could indicate a site of penetration into the globe on the ventral side here that we just maybe didn't sample a full thickness defect in the sclera here. But this inflammation and this attached muscle and fibrosis here is kind of suspicious. This dog does happen to be from California. And a lot of times we would suspect like a migrating grasshopper or something along those lines. But a little piece of information that I did hold back from you guys is that prior to all of these signs starting, this dog had an altercation with a bush. So the patient ran into a bush about 1 week prior to all the clinical signs that they were seeing in this eye. And despite them not finding a foreign body on their exam and during enucleation, it was in the globe itself. We were quite lucky to catch it in section. You can see how tiny that piece of plant material is. We don't always catch it. But again, all those neutrophils are pretty suspicious that there might be a contaminated penetrating trauma. And again, with that episcleral reaction as well, that could point to signs of that. So, it's a fun little trauma case. All right, and then next up, this is an 8-year-old male neuter domestic short hair cat. Let's see. This patient presented with a 1.5-month history of mydriasis in the left eye that progressed to become blood in the eye. So when the cat presented to the ophthalmologist, it had complete hyphema and secondary glaucoma with an IOP of 48. They do note that the Doppler blood pressure was normal and the blood work was unremarkable, and that the other eye had no other ocular abnormalities. So this is our hemisection of our formalin fixed globe. So we've got cornea at the top. We can see a little red tinge fluid here in the anterior chamber. So that would go along with their hyphema and kind of blood in the eye, which is also present here in the vitreous. But the main feature here is this big tan mass that kind of overlies and replaces the central retina and overlies the optic nerve head here. And so that is going to be what we take a look at histologically. Right, yeah. So again, cornea at the top. We can see our iris leaflets aren't maybe as long as thin as they should be. So they're kind of a little nubbed and kind of stubby and maybe lying across the back of the cornea there. Here's our lens. Got a little bit of hemorrhage here. And then here is our mass. You can see here's some detached retina kind of coming off of it. It just kind of replaces the central retina and the optic nerve head. And you can see maybe where it is in the optic nerve itself, just a little bit here. All right. So we'll go ahead and start with the mass itself. So again, kind of right in the back here, here's their retina that blends with this mass that completely effaces the retina here. And again, we can see where it trickles into the optic nerve just a little bit here. But good news is that our optic nerve towards the surgical margin looks very clean. So this mass was removed with clean margins. And if we take a look, we've got a neoplastic population of these spindle cells that are kind of intersecting and kind of whirling in some places, and they're looking very nerve-like, so kind of like glial cells. So they have indistinct cell borders with this eosinophilic kind of fibrillar cytoplasm, the nuclei around oval with the stipple chromatin and a couple prominent nucleoli. It's not very mitotically active. I think there were 0 mitotic figures in the count here. We do have some blood vessels supporting the neoplastic cells here. We've got a couple of hemosiderin-laden macrophages and some free erythrocytes, so a little bit of hemorrhage and chronic hemorrhage in this mass. Here's just a nice spot where, again, kind of blends in and effaces the retina here. So here's the retina that is diffusely detached and quite atrophied for the rest of the retina. And then otherwise with this eye heading back towards the front, there's some of that hemorrhage here, and we can tell that our irises are shortened and nubbinified, if you will, by this fibrovascular membrane that causes some nice ectropia on uvea, so it's pulling the iris leaflet forward towards the cornea. We do have a little bit of some blood vessels and a little bit of neutrophils, some keratitis in the periphery of the cornea. And then just to show this one's a little bit more broadly attached here. So broad anterior synechia, again, being caused by this little fibrovascular membrane. So a tumor in this location and this morphology here is consistent with a like a retinal optic nerve head glioma. Normally, gliomas in the central nervous system are further categorized, but we don't really usually do that with our intraocular gliomas. They're usually poorly differentiated, which, if it was in the central nervous system, would maybe suggest a poor prognosis. But I guess we found that these masses, when they have clean surgical margins, like we have in this case, usually have a fairly good prognosis.
Why do you name them in blue-eyed dogs?
Why do we name them? Are you talking schwannomas?
Sorry, never mind.
Don't
It was
know.
originally spindle cell tumor in blue-eyed dogs, and then it was named more descriptively from there, so I don't know. Yeah.
So when we talk about, it's a nerve tumor, most people, I think, when they're starting out, immediately assume it's going to be neurons, when it's actually rarely neurons. It's almost always supporting cells in there. So gliomas far outnumber our nerve-based, new nerve origin tumors. And so if you hear nerve tumor, it's usually not the actual neurons themselves. It happens, but it's rare.
Awesome.
Benedict says, please repeat.
I was talking to a microphone. Can you repeat it for me?
Dr. Gasper was just saying that when people think of nerve tumors, that they are thinking that maybe it might be neurons that are the culprit in the neoplasms, but really it's the supporting, like, glial cells and such, and those are by far more the common nerve tumors that we see in our animals.
Don't ask why is it a schwannoma blue-eyed?
Oh, right. And then why is it a schwannoma in blue-eyed dogs? Because they can get a similar glial cell proliferation in the iris stroma. And that was just not really a good answer for that. So retinal and optic nerve glioma in this kitty cat. All right.
All right. Yeah.
Yay.
All right. Hello, this is Gillian. The next case is supposedly a 20-year-old red-eyed tree frog. I don't know if that's a typo or if that's honestly true, but here it is, the patient with a history of acute onset eye change, November 28th, noted by the keepers. Photos were concerning for corneal rupture with globe collapse, so they started on systemic antibiotics and meloxicam and topical ofloxacin. Seen in person on December 1st, so about 3 or 4 days later, and the eye is ophthalmic with significant pigment intraocularly, concern for rupture or intraocular mass, question mark. Enucleated on December 9th, and eye continued to be more ophthalmic than initial pictures. So I think this is probably the initial picture here, where it looked like there was a corneal lesion and there's some corneal opacity. And then here is probably closer to enucleation. I'm not sure what this is, maybe a Doppler probe doing something with, and I don't really know. Anyway, I'm not an amphibian veterinarian. So anyway, so here's the eye. You can see how ophthalmic it is. It's really protruding, especially compared to the other eye. Frogs in general, I think clinically have very narrow anterior chambers or shallow anterior chambers. So it looks, if you were comparing this to like a dog or a cat, you'd be like, wow, that anterior chamber is collapsed, but actually that's pretty normal for frogs as far as I know. So we got a small globe, and it had significant corneal opacity and it was protruding. We ended up submitting both halves, and we did not take a gross photo of the eye, but luckily we got these beautiful clinical photos from the submitting clinician. So let's go ahead and look at the eye. It's a small enough eye that we can pretty much see all of it at this magnification, so no need to go do the subgross thing. So here is the cornea, and you can see that the cornea is discontinuous and there is some pigmented tissue protruding up into that location. So there is an extensive corneal discontinuity with uveal prolapse, so that's iris prolapsing up into it. Similar here. So here's more normal cornea here, and then it's just absent. Here's that uveal tissue with some hemorrhage protruding into it. And then we have a lot of just brightly eosinophilic material, a little bit more basophilic on the surface. So let's go ahead and dive right in. And actually at low mag, you can see there's some really large purple structures here. Here's a little bit more pigmented stuff. So there is a corneal defect here, a pretty extensive one. At this magnification, you can see here's corneal stroma and here's Descemet's membrane, which is discontinuous and a little bit curled here. So there is a full thickness corneal defect. And as we go higher mag, some of this might be remaining corneal stroma that's sort of compacted. It also could be some sort of fibrinous sort of exudate. Here in the more superficial aspect of this, we have some pigmented stuff, which is actually plant material. And then we have some more basophilic structures and accumulations of things in this, what is essentially a serocellular crust. We have a bunch of cells here. Some of these might be nucleated red blood cells that have loss, that are sort of degenerate, and they could also be a mix of inflammatory cells. So here we can see the corneal stroma where it's still intact. It is pale, and its stromal lamellae are separated by clear space. So this is corneal edema. And then we also have quite a few cells in the corneal stroma. So there's a keratitis here as well. We look higher mag. A lot of these cells are probably heterophils. And then some of them might also, these larger ones might be macrophages here to help with a corneal issue. And somewhere in here, there are lipid-laden macrophages, which I might remember to try to show you. So there was probably a pre-existing lipid keratopathy. So as we look into this serocellular crust, it's really exciting for a pathologist. There are so many things here. So we have some more, oh, it's so cloudy. There are there's some linear structures, and then, some more rounded structures. The rounded structures vary in size quite a bit. Some of them could be bacteria. Some of them could be some sort of fungal structures. We have these larger structures here that have sort of a ill-defined boundary with some rounded structures in the center. These could be fungal structures with some endospores of some sort. And out here, you can also appreciate more of the sort of fibrillar organisms, which I think are fungal hyphae. Some of the rounded structures might actually be protozoa as well. I'm not actually sure what they are. More on that in a moment. These accumulations of things here, I think, are bacterial colonies of cocci. And here's that plant structure. So this could be some sort of bedding that kind of got stuck to that protruding cornea.
Bedding with a fungus.
Yeah, right. The fungal plant material often carries along its own fungal sort of biome with it. You can see in what I think is corneal stroma here, some fungal hyphae. So there's an invasive fungal organism here as well that was probably opportunistic all along. And here you can see it's reaching toward the iris that's prolapsed here. So this pigmented tissue here is iris, and you can see these fungal hyphae extending through the iris tissue below it as well. So I do have a PAS stain, which I can show you. We have our eye in a different orientation, which is always exciting.
They always get turned back.
Yeah, good question. Oh, it's not as pretty on the screen. Here's one structures. Here's none. The colors get much more vivid on the screen thanks to some sort of correction by the camera. It's not quite as garish under the scope here. But hopefully you can see that the PAS is highlighting not only these larger structures, but also the myriad fungal hyphae that are in the stroma here. And I can't remember if it highlighted the rounded structures as well. So Dr. Gasper is pointing out that these look like thalli, and the significance of that in amphibian pathology is that the invasive, horrible fungus called chytrid, shortened to chytrid, I can't remember the full name. Yeah, thanks, guys. Whatever. We're gonna call it chytrid. Is a really significant pathogen in amphibians. However, these thalli are quite a bit larger than those seen with chytrids. So with Dr. Gasper's input, I decided that these were not actually chytrid. I did also initially assume that because they were only present in the area of the ruptured cornea, that they were not actually pathogenic and that more likely are opportunistic fungi in this case. But my goodness, they're certainly pretty. The other rounded structures, their identity is still unknown. They could be some sort of fungal structure. They could also be an alveolate parasite. Is that correct?
Yeah.
Okay. So, which is a protozoa, is that right? Okay, yes. So, however, I don't actually know what they are, but that was a possibility. And once again, because these organisms were only present in the affected parts, where the cornea was ruptured, I assumed that they were opportunistic. Let me see if I can find the lipid-laden macrophages here. Because I think it's possible that this frog's cornea was diseased prior to developing this. It's a little bit hard to really say with much confidence. There are some vacuolated cells here in the corneal stroma. These could be some lipid-laden macrophages. However, given the corneal stromal edema, they could also just be macrophages that are drinking up some of that edema fluid. But I did suggest that maybe this frog had lipid keratopathy, which is a common problem in captive amphibians, and it's probably diet related, from what I understand. So that's about it. So they mentioned Buphthalmus, and I felt that the retinal layering was not consistent with glaucoma. Even from this low mag, you can see this really nice layer of retinal ganglion cells. We also have the internuclear layer and an outer nuclear layer. So I did not see any signs of retinal atrophy that I think would indicate that glaucoma really predated, or that was, certainly this was not a chronic glaucoma globe if it was glaucomatous. It's a little bit hard to confidently evaluate the iridocorneal angle, in part due to the anterior chamber collapse associated with the corneal rupture, and also because I am not an amphibian ocular specialist. So I'm not entirely sure if this is normal. There's certainly some red blood cells there in the angle there. But ultimately, if it was glaucomatous, I think it was probably more of an acute glaucoma, probably associated with the corneal disease leading to anterior chamber collapse, rather than a pre-existing glaucoma. So that is that case. I'm going to throw that slide on the floor. So here were my, thanks. Here are my morphs, quite a few here going on. But I did propose that there may have been a pre-existing lipid keratopathy, although the other eye looked fine. So I think typically that's probably more bilateral, but maybe it can be unilateral. Okay, good. Anyway, there was some mild intraocular inflammation, and there was a cataract, which could have been secondary to the corneal perf as well, or it could have been a pre-existing cataract. Anyway.
Something I didn't mention before was that if we see chytrid, it usually only occurs in keratinized epithelium, and there's keratin here. So, and there's a whole bunch of different organisms that are similar to the chytrid that we usually see, and they can have a lot of different morphologies. And mentioning the alveolate parasites, those are more commonly associated with visceral disease in frogs and toads. And so seeing them at the ocular surface, I'm not sure. If somebody wants to look that up, it's Perkinsus-like organisms.
Cool. Yeah, thanks. Hopefully everyone heard that from Dr. Gasper. And I consulted with him in trying to decide whether this was actually chytrid. So thanks for that help. Okay, cool. We have a few minutes left, and I have a quick fun case. This is we got some conjunctival tissue from a horse. Let's see here. It was a 10-year-old castrated quarter horse. And we had some beautiful clinical photos. It was a bilaterally affected horse, so we got tissue from both eyes. You can see these nodules in the palpebral conjunctiva here. And I think this is one that's kind of in the fornix as well of the right eye. There might also be some in the periocular tissue as well, excuse me. Here is one of the pieces of tissues bisected, and the grocer wrote a beautiful little description. They said, let's see here. Nodules are these adorable targetoid / onion-like encapsulated doodles. So here is a nice image of one of those. You can see how lamellated the material is in the center of this tissue. So let's go ahead and take a quick look. This is a fun little quick case. So this is just one of the slides. We had 2 slides. And here we can see this lamellated structure with a bunch of stuff in the center, and then we have these like layers of material around it, and a more basophilic layer around its periphery, surrounded by some loose conjunctival substantia propria. And this is actually a decent one to start with. Well, let's go to this one. So the gooey centers of these are composed of degenerate inflammatory cells. Probably a lot of these are neutrophils, but a lot of them could also be eosinophils. But you can see they're very degenerate at this point. And in this one in particular, we can see we've got a few little linear eosinophilic structures. So these are actually nematode parasites that are maybe degenerate, variably degenerate here. I never really saw any evidence of reproductive structures in any of these guys, so I assume they are larval nematodes. Let's see here. Here's another cute one. So yeah, pretty degenerate, which is not surprising considering what they're surrounded by. When we look out in the outer rim here, you can appreciate that there are quite a few eosinophils as well as some other inflammatory cells of all the kinds. So these are eosinophilic granulomas surrounding larval nematodes. And the most likely species, or one of the most likely species, is probably Habronema, which is spread by a fly vector of some sort. I can't remember which one. And so these also cause, I think, summer sores, but the eye is one of the more commonly affected tissues in horses. So hopefully that was all accurate.
Call pasture potato. This one looks like a pasture oyster.
Pasture potatoes. Well, I've never heard that one. That's awesome. Anyway. Very nice. So anyway, multifocal mineralized eosinophilic granulomas with interlesional nematode parasites, Granulomatous conjunctivitis, and I assume they're Habronema species, but that's about all I have to say. So it's probably 9 o'clock. Thank you very much for your attention and all that stuff. And we'll see you in 2 weeks for rounds in 2 weeks.
Thanks, everyone.
Yep. Thanks. Okay, so I need to